Good day everyone. Today we're going to discuss about maxillary injection techniques for maxillary anesthesia. Now, what is special about this maxilla? Maxilla is quite different from mandible in its anatomical and histological structure. It has a very thin cortical bone which is well pneumatized with multiple nutrient canals and is highly vascular. Now, these are the factors that are very important when we consider the maxillary anesthesia. Because of the thin cortical bone that it is, the local anesthesia easily tends to penetrate through the nutrient canals and also the thinner cortical bone and reaches the teeth. Hence, most often a supraperiosteal block in terms of infiltration always works well in maxilla. However, when you look at the mandible, the difference is that the mandible has an extremely thick cortical bone which is got very minimal number of nutrient canals, because of which infiltration often does not work. The second important factor that we have to consider in maxillary anesthesia techniques is that it is extremely vascular. The whole area of the maxilla is surrounded by important vasculature that supply the head and neck. So, the chances that you have the duration of anesthesia can be minimal when you are using a maxillary infiltration compared to a mandible. And the other thing about the vascularity is the complications of anesthesia like hematoma are higher when we look at maxilla compared to mandible. So, having understood the anatomy of the maxilla and how it influences the anesthesia techniques that we're going to discuss, let's move on to our next section. That is the course of the maxillary nerve. As you can see, the maxillary nerve starts from the Gasserian ganglion, which is located at the apex of the petrous part of the temporal bone. From here, it courses in the lateral wall of the cavernous sinus, exits the skull through the foramen rotundum. What you're seeing is the foramen rotundum, which is only appreciated on the cut skull from the skull's interior. Once the nerve exits the foramen rotundum, the next situation is it enters the pterygopalatine fossa. Pterygopalatine fossa is technically bound anteriorly by the posterior surface of the maxilla. Posteriorly, it is bound by the pterygoid plates, and the medial boundary of the pterygopalatine fossa is the perpendicular plate of palatine bone. Now, this area at this point, till this point, the maxillary nerve does not give out any branches. Once it enters the pterygopalatine fossa, it suspends the pterygopalatine ganglion, the one that is highlighted in green. It suspends the pterygopalatine ganglion through the ganglionic branches. After this, it gives out two important branches, that is the zygomaticofacial and the zygomaticotemporal. The zygomaticofacial supplies the skin over the malar prominence by passing through the cheekbone or the zygoma. Then the next branch, that is the zygomaticotemporal branch, supplies the skin over the region of the temple and also the zygomatic arch. After this, through the pterygopalatine ganglion, there are various branches that are given out, and that include the orbital branches, which will pass through the inferior orbital fissure and supply the orbital mucoperiosteum. We have the greater palatine branch, which descends through the greater palatine canal and then supplies the palatal mucosa. We have the nasopalatine branch, which is technically the spinopalatine branch, that exits the pterygopalatine fossa on its medial surface and supplies the nasal floor and the anterior gingiva. And then we have the pharyngeal branches, which go and supply the pharyngeal mucosa posteriorly. So, these are the branches of the maxillary nerve that pass through the ganglion and then go and supply the mucosa in all these areas. To list out again, we have orbital branches which supply the orbital mucoperiosteum. The second set is the nasal or the spinopalatine branch that supplies the nasal floor and exits through the nasopalatine foramen in the anterior maxilla and supplies the anterior palatal mucoperiosteum. The third is the palatal branches, which include the lesser and the greater palatine nerves. These two nerves supply the complete palatal mucoperiosteum, which is completely sensory in nature. The fourth one is the pharyngeal branches, which supply the mucosa of the pharynx. So, once these ganglionic branches are given, then the nerve courses forwards and then forms the posterior superior alveolar nerve, which is a branch of the maxillary nerve. Now, this posterior superior alveolar nerve partly travels under the mucoperiosteum, that is outside the bone, and few of the branches of the PSA enter the bone. Now, once they enter the bone, they form something called the posterior superior dental plexus. Inside the bone, they form the posterior superior dental plexus. Now, this dental plexus, the posterior superior alveolar dental plexus, supplies the third molar, the second molar and the first molar. So, these three teeth are supplied by the posterior superior alveolar nerve. In 28% of the cases, the first molar, the mesiobuccal root, as we all know, the first molar, maxillary first molar has three roots, the mesiobuccal, the distobuccal and the palatal roots. Now, the mesiobuccal root of the first molar in 28% of the cases may be supplied by the middle superior alveolar nerve. After giving out these branches, the maxillary nerve continues in the anterolateral wall of the maxilla and then forms the middle superior alveolar nerve and the anterior superior alveolar nerve. Now, the middle superior alveolar nerve supplies the two premolars. The anterior superior alveolar nerve supplies the teeth from the canine to the ipsilateral, that is to the same sides, central incisor. So, this is the complete course of maxillary nerve. After it gives out these branches within the bone, the nerve terminates on the face by exiting as the infraorbital nerve. The terminal branch of the maxillary nerve is very important, which is nothing but the infraorbital nerve. Now, this is the one that it's got three further branches, that is inferior palpebral that supplies the lower eyelid, the lateral nasal branch which supplies the lateral wall of the nose and the superior labial branch that supplies the upper lip. So, this is the complete course of maxillary nerve. So, when we anesthetize the maxilla, we can either give an infiltration, we can give a block, we can block branches of the maxillary nerve, or we can block the nerve in toto. And that is the objective of today's lecture, where we're going to learn how we're going to give anesthesia to the maxilla and how can we block the complete nerve as such. Okay. So, hope you've understood the anatomy of the maxillary nerve. Moving on to our next situation. So, this is the summary of the maxillary nerve. We're seeing that this is a Gassedian ganglion. This is the maxillary nerve exiting through the foramen rotundum, and then these are the zygomaticofacial and the zygomaticotemporal branches. This is the posterior superior alveolar branch which is coming inside and forming the posterior dental plexus after it enters the sinus. The rest of the nerve travels forward in the anterolateral wall of the maxilla, where it forms the middle superior alveolar and the anterior superior alveolar dental plexus. After it gives out these branches, the nerve comes out of the antrum, that is, it exits the antrum and enters the face through the so-called infraorbital foramen, where it divides into the last terminal branches, that is the inferior palpebral, the lateral nasal and the superior labial. So, that is what we have rehashed here again and the course of the maxillary nerve. I hope it's been clear so far. Now, when you're looking at the dentate segment, the palatal mucosa, when we do an extraction of a tooth or any surgical procedure per se on the maxilla with local anesthesia, we need to know which in all areas are supplied by which nerve, so that we choose the right kind of anesthetic block to achieve anesthesia. Now, when we look at it, the infraorbital nerve, the terminal branch, supplies from the central incisor to the canine and also the upper lip. The middle superior alveolar gives its supply to the premolars. The posterior superior alveolar nerve supplies the molar teeth except for the mesiobuccal root of the first molar and this happens only in 28% of the cases. In 28% of the cases, the mesobuccal root is supplied by the middle superior alveolar nerve. Then the complete palatal mucosa from the third molar till the region of the canine is supplied by the greater palatine nerve, which is exiting through the greater palatine foramen. Then the mucosa, the palatal mucoperiosteum from the canine till the opposite side canine is supplied by the nasopalatine nerve. So this is the nerve supply of the teeth and the soft tissues enclosing the maxilla. Having discussed that, let's move on to the next thing. How are you going to anesthetize the maxilla? What are the various ways in which we can anesthetize the maxilla? So when you look at a tooth which is undergoing an extraction, now we can block the nerves that are entering the tooth and that are present in the periodontal ligament membrane, so that we can still perform the procedure in terms of extracting the tooth. And that is what we do in terms of infiltration. Now, infiltration is a process in which we anesthetize the terminal nerve fibers, that is the main branch, its divisions, and then the terminal branches which are entering the tissue. So, infiltration is only given in areas where the incision is placed. So, you just flood the area where you are placing your incision by giving local anesthetic solution. That is what is a infiltration. Now, field block does not include these fibers, but it includes a little more bigger branches that supply the particular area of surgery. So, in a field block, the site of deposition of local anesthetic is away from the site of surgery. However, it still does not block any of the named nerves. Having understood this, now let us look at nerve blocks. Nerve blocks are the blocks in which we give anesthesia to a particular nerve. Let us say a named branch or division of the maxillary nerve. That is why we have infraorbital block, we have posterior superior alveolar nerve block, we have middle superior alveolar nerve block, we have greater palatine nerve blocks. So these are all the bigger nerves that supply a defined area. Okay, whereas a field block and infiltration are supplying unnamed nerves which are just arborizing or branching from the main nerve to carry the impulses from different areas of the different regions of the maxilla. So, in this lecture, we are going to focus both on learning how to give infiltration and also how to give nerve blocks in the given area. Now, moving on to the nerve blocks that we give. The first nerve block that we are going to look at is infraorbital nerve block. Now, infraorbital nerve block this is the infraorbital nerve. As discussed, it is a terminal branch of the maxillary nerve that exits from the maxillary antrum through the infraorbital foramen and divides into its terminal branches, that is the inferior palpebral supplying the lower eyelid, the superior labial supplying the upper lip, and the lateral nasal branches which supply the nose. Other than this, the branches from within the bone tend to supply the three anterior teeth, that is the central, lateral and the canine teeth of the same side. Now, when we anesthetize the nerve, that is the infraorbital nerve, we will see that all these three terminal branches along with the anterior superior dental plexus which is within the bone, all of them do get anesthetized. So that is the reason why. Now, where is this nerve block indicated? If we have procedures of the upper lip, we have procedures involving the anterior teeth from the central incisor to the canine, or we have procedures involving the anterior wall of maxilla lateral wall of nose and medial third of the eyebrow, of the eyelid, of the lower eyelid. That is where we tend to give an infraorbital block. To repeat again, anterior 3 teeth, the upper lip, ipsilateral half, the same side of the upper lip, the lateral wall of the nose or the lower eyelid, the medial third, or procedures involving the anterior wall of maxilla. That is where we can comfortably give an infraorbital nerve block. Now, let us look at how do we position the patient. The patient is always in any kind of maxillary procedure, excuse me, the patient is sitting with his head reclined. Always give anesthetic agents in a semi-supine position because it will avoid the chances of patient going into vasovagal syncope. So, recline the patient, put the patient at an angulation of 45 degrees and make sure that the patient is below the level of your shoulder by 4 inches. Ask the patient to open his mouth wide and then see that the maxillary plane is inclined at 45 degrees to the floor. This is a position that is indicated for any kind of maxillary procedures. Now, when the other way in which you can reach the infraorbital foramen, that is this particular area, is when you ask the patient to look straight. When you ask the patient to look straight, you have to remember that the supraorbital notch, the infraorbital notch, the pupil of the eye, the infraorbital foramen and the mental foramen lie in one straight vertical axis. So, if you have a difficulty in identifying the position of the infraorbital foramen, ask the patient to look straight. That is when you will palpate the infraorbital notch, and when we dip our finger down, we will get to the infraorbital foramen, which is a small depression that is present below the infraorbital notch. This is the infraorbital notch on the infraorbital rim. That is the notch. Right below that will be the foramen. So, you palpate the notch and then you palpate the foramen. Okay, and the best way is ask the patient to look straight, then all these fall on the same vertical axis. Having located the infraorbital foramen, the next thing is how are we going to block this nerve? Now, there are various techniques to reach the infraorbital foramen. You can choose, you can place your needle in the mucobuccal fold of the first premolar, go straight up, then we reach the infraorbital foramen, or you incline the needle from the central incisor, even then we will reach the infraorbital foramen, or we can go percutaneously through the skin and then after palpating the foramen, we can go percutaneously through the skin and then deposit the local anesthetic. Even then we can block the infraorbital foramen. So, based on this approach, we have 3 different techniques to block the infraorbital nerve. The central incisor approach, the extraoral approach and the first premolar approach. The most commonly practiced approach is the first premolar approach. So, now let us look at how we are going to give the block. Now, what are the landmarks? As we have discussed, we are going to palpate the infraorbital notch and move the finger down from the infraorbital notch. Then we will feel a small dip in the area adjacent to the nose. In the paranasal area, we will feel a small dip. That dip corresponds to the region of the infraorbital nerve. Okay, having identified this, now take your local anesthetic syringe parallel to the long axis of the first premolar. So, you palpate the infraorbital notch with your index finger, retract the cheek and take your local anesthetic syringe parallel, insert it into the height of the mucobuccal fold, that is into the point where your cheek mucosa is meeting your alveolar mucosa. That curvature, this curvature where your cheek mucosa is meeting the alveolar mucosa, that's called the mucobuccal fold. So, we place the needle or insert the needle into the height of the mucobuccal fold parallel to the long axis of the premolar, and once we enter inside, we can feel the needle coming up. When we can palpate the needle with your finger on the surface, that is when you stop. Once you stop, aspirate in that area and then deposit the local anesthetic. That is the first premolar approach, wherein we are taking the needle parallel to the long axis of the first premolar till the needle is felt by the operator under his finger, which is placed on the surface. So, we have one finger on the surface, other finger to retract the cheek as shown in the image here, and then insert the needle. Once you can feel the needle below your finger that is placed extraorally, that is when you stop, you aspirate, and then you deposit your local anesthetic. So, that is the first premolar approach. The next one is the central incisor approach. As mentioned, you take your needle, angulate your needle from the meso-incisor line angle towards the distogingival line angle. That means you are going across the central incisor and entering the mucobuccal fold of the in the region of central and lateral incisor. From there, you advance the needle upwards. Once you advance the needle upwards, you will advance it till it is felt under the finger here. Till it is felt under the finger here, which is placed on the infraorbital foramen. Once you have done that, you will stop advancing any further, aspirate, and then deposit the local anesthetic. This is the central incisor approach. Now, you would use a central incisor approach if you have an abscess that is present in the region of the premolar. That is when we cannot go into the abscess and then inject. That is when we would opt for a central incisor approach. The last one is an extraoral approach, wherein we go and identify the nerve and then block the nerve by percutaneous injection. This is the extraoral approach to block the infraorbital nerve. Now, having seen this, where does your nerve rest? The nerves, where does the needle rest? The final position of the needle is between the two muscles, that is levator labii superioris and levator labii superioris alegnesi, and it is at the infraorbital foramen. That is where the final position of the needle is, that is levator labii superioris alegnesi and levator labii superioris. Between these two muscles, that is where your foramen is located. That is where the final position of the needle is, so that we can block the nerve. Now, what are the areas that are anesthetized? As we have discussed earlier, whenever we give an infraorbital block, we give anesthesia to the central, lateral and canine teeth of the same side, and also block the upper lip, the lateral wall of the nose, and also the medial third of the orbit. So, technically, complete anterior wall of the maxilla and the skin over it are anesthetized along with the three teeth, that is the central incisor to the canine. Now, after you have done this, how do you check for anesthesia? The subjective symptoms that the patient is going to say is that he has got numbness in all of this area, that is the lateral wall of the nose, lower eyelid, cheek, and also the upper lip, the ipsilateral half of the upper lip. He will say that his mucoperiosteum over the teeth of central, lateral and canine is also numb, and also he will not have any pain when you are trying to extract the teeth or perform any procedure on the anterior three teeth. Having done this, what are the complications of this procedure? Commonly, there can be incidence of hematoma. However, it is less compared to that of posterior superior alveolar nerve block. The second thing is, if you do not place your finger on the external surface, sometimes we may advance the needle too much into the tissue. So, there are chances that you can go and injure the globe if you are extremely careless. And then the local anesthetic that is deposited here may seep into the orbit and cause sometimes diplopia, which is a very rare complication. The injury to the globe and diplopia are rare complications. However, you need to have them in mind so that we know how to deal with them, because all of these things, the diplopia is reversible, because once the local anesthetic effect is gone, the diplopia tends to reverse. But the more grievous complication is the injury to the globe. So, it is extremely important that the operator identifies the position of the infraorbital foramen and does not advance the needle more than that into the tissues to avoid the complication of injury to the globe. I hope we have understood the infraorbital nerve block. Thank you. Sorry. The next one that we're going to look at is a posterior superior alveolar nerve block. Now, posterior superior alveolar nerve, as we have discussed, is a branch that arises from the maxillary nerve in the pterygopalatine fissure, in the pterygopalatine fossa. Few of the branches run outside the bone, whereas part of the nerve enters the bone. So, the part that is outside the bone tends to supply the buccal gingiva or the 3 molar teeth, whereas the part that runs inside the bone forms the superior dental plexus, that is marked in red, forms the superior dental plexus and supplies the teeth through the root apices. Okay. So, where do we anesthetize this nerve? We anesthetize this nerve when it is exiting from the pterygopalatine fossa and entering the posterior wall of the maxilla. The needle is on the lateral side, posterior lateral surface of the maxilla. The needle is on the, this is the posterior side and this is the lateral side. So, this is where we tend to block the nerve. What are the areas that we anesthetize with this? We anesthetize all the 3 teeth and also the buccal gingiva of that area. So, this is what we need to understand. This is the posterior superior alveolar nerve running in the soft tissues, whereas this is the part that is running within the maxilla forming the posterior superior dental plexus. Now, when you have to reach this point, what are the landmarks that we have? So, we have to reach the posterior surface of the maxilla to block this nerve somewhere here. So, how do we reach this? When we have to go to the posterior surface of the maxilla, the landmarks that we need to consider is the second molar tooth, then we have the maxillary tuberosity and the mucobuccal fold. So, we have the mucobuccal fold, we have the second molar tooth and the maxillary tuberosity which is right behind the second molar. Now, once you have identified these landmarks, how do you insert the needle? When you are trying to give a posterior superior alveolar nerve block, ask the patient to keep his mouth partly closed. So, when he keeps his mouth partly closed, we will see that the condyle and the coronoid are slightly posterior, that is, they translate back so that we have adequate space within the cheek. So, the patient should not be opening his mouth very wide, it should be partly closed. Then, take your needle and the needle has to be directed at 45 degrees to the vertical, 45 degrees to the horizontal and 45 degrees it has to be medially directed. So, it does not go in straight, but it goes in medial direction. So, that is the second molar tooth that we have, and then it is going at 45 degrees in all the 3 planes, that is to the vertical, to the horizontal and also medially it is going at 45 degrees. So, that is when we can reach the posterior superior alveolar nerve. Now, what are the considerations that you have when you are trying to block the posterior superior alveolar nerve? We cannot use a long needle. We need to use a 1-inch needle, which is a 25 millimeters needle. We use a 1-inch 25 millimeters needle and we insert it only 2/3 into the soft tissue. The needle should be inserted only 2/3 into the soft tissue. The last 1/3 is left outside, because the deeper you go, we need to remember that there is a pterygoid venous plexus and maxillary artery which are sitting right next to the posterior superior alveolar nerve, which can get injured when we go in more deeper. So, what should we remember? We have to remember that we use a short needle of 25 millimeters and only 2/3 of it penetrates into the tissue from the second molar tooth. So, once you have reached this area, make sure that you aspirate in this area, because as I have told you, this area is highly vascular and has the pterygoid venous plexus, because the pterygoids are giving origin to your lateral pterygoid muscle, and around the lateral pterygoid muscle is our pterygoid venous plexus. So, you have to be extremely cautious that you don't prick any of this by over inserting your needle. So, do not use a long needle. You use a short needle which is 25 millimeters in length, and the gauge of the needle can be 25 or 27, whatever is available at your comfort, and make sure you aspirate in two planes because we have a beveled needle. Once you aspirate, only then deposit your local anesthetic. Now, how much will you deposit? For all large nerves, we deposit around 1.2 cc of local anesthetic in the given area. That is, at this point, or as you can see at this point, we deposit 1.2 cc. Don't inject rapidly because some patients could be allergic to the local anesthetic agent. So that is why do slow injection, inject at the rate of 1.2 cc over a minute's time, and that is how we deposit the local anesthetic. Now, once you have deposited the anesthetic, wait for 5 minutes. Once you wait for 5 minutes, we know that the nerve is adequately bathed in the local anesthetic agent. Then you can check for the anesthesia. How do you check for anesthesia for a posterior superior alveolar nerve block? We have already discussed that it tends to give nerve supply to the buccal gingiva of the molars. So, when you take a blunt probe, a Moon's probe is a blunt probe, when you place that and then give some amount of pressure over the buccal gingiva, the patient will not have any pain. That confirms that our posterior superior alveolar nerve block is working adequately. Okay. However, in this case, the patient will not say any feeling of heaviness and numbness in the soft tissues because the cheek does not get any supply from the posterior superior alveolar. So, there are no subjective symptoms for a PSA block, but you can objectively demonstrate the anesthesia by using a blunt probe and application of pressure in the region of molar, second molar or the third molar. So, that is posterior superior alveolar nerve block. Now, we have discussed what is the final position of the needle. Now, when we are looking at complications, as we have discussed, the most common complication of a PSA block is a hematoma. This hematoma, as we have discussed, usually occurs because we have injured the pterygoid venous plexus by taking the needle more deeper, or we have used a wrong needle. Now, if we have a hematoma, how are we going to deal with it? We are going to apply pressure in the region of the maxillary tuberosity, directing the pressure upwards. However, most of the times it is going to come down by itself because the veins tend to collapse until and unless you have gone too deep into the pterygopalatine fissure to injure the maxillary artery. Otherwise, it is going to subside by itself. Ask the patient to apply, after you have applied pressure, discharge the patient home and ask him to give a lot of cold packs so that the hematoma regresses by itself. So, that is posterior superior alveolar nerve block.